who is Associate Professor in the H. Milton Stewart School of Industrial and Systems Engineering at Georgia Tech. She's also Director of the Center for Operations Research in Medicine and Healthcare, and is a Senior Research Professor at the Atlanta VA Medical Center. Dr. Lee earned a PhD at Rice University in the Department of Computational and Applied Mathematics and received her undergraduate degree in mathematics from Hong Kong Baptist University. Dr. Lee works in the area of mathematical programming and large-scale computational algorithms with a primary emphasis on medical and healthcare decision analysis and logistics operations management. In medicine and healthcare, she has developed real-time computer decision support systems to help analyze large-scale biological, DNA and genomic, and clinical data to assist in health prediction, early disease prediction and diagnosis, optimal treatment design and drug delivery, treatment outcome analysis and prediction, and efficient and cost-effective healthcare delivery and operations logistics within healthcare systems and processes. In 2005, she received the Informs Pierscala Best Paper Award for Research Excellence in Healthcare and Management Science for her work on emergency response and planning, large-scale prophylaxis dispensing, and resource allocation for bioterrorism and infectious disease outbreaks. Most recently, she and doctors from Memorial Sloan Kettering Cancer Center were awarded the 2007 Informs Franz Edelman Award for Outstanding Practice of Management Science and Operations Research for their work using OR techniques to develop new therapeutics for prostate cancer. Today, she will be speaking to us about modeling and optimizing the public health infrastructure for emergency response to bioterror attacks and infectious disease outbreaks. Please join me in welcoming Dr. Eva Lee.
Thanks, Susan, for the introduction and also for inviting me to present the talk. And I guess there are many, the earlier speakers, Margaret and Richard, already talked about what we do and how broad the area is. So I'm going to look at some of the issues related to modeling and optimization of the public health. First, I want to thank the research team that consists of the Georgia Tech students and also a team of researchers from CDC as well as many different emergency response and also healthcare workers across the nation. So what we are looking at is city readiness. So city readiness is really not just for bioterrorism. And you could imagine that our project actually back in 2002 really was about infectious disease outbreak. And it's not so much just about like pandemic flu, because actually if you look at this talk, it is not designed for pandemic flu, and I will mention that. It's really looking at infectious disease and how do you actually take care of your regional population, how do you protect them? So that's the key part. So it involves multi-level of the operation planning of the public health infrastructure, and also the idea here is really to protect the regional population. That means you're going to take care of everyone, not just the ones that can afford it, so that includes the homeless people, people in the prison, and people in assisted living, those that are in airport and every parts. And so some of the challenges include like strategic stockpile. How do you actually take care of the medications? How do you send those distribution around the country? And how do you actually set up the facilities? These are temporary facilities that you have to set up. How do you route the population? As Rich already mentioned, if you're going to do evacuation or if there's any emergency, you cannot just ask everybody now go. They're not going to know where to go. Everybody is going to choose several of the routes that they are familiar with, and then you will all be stuck somewhere instead of getting to the target place. So there's many different infrastructure. Here, just to show you a county, if you look at, that's like just a population coming in. That's the central commander that's in charge of things. So if we look at the medication flow when it comes to biological attack or infectious disease outbreak, so again, it's not just about terrorism, but it's more infectious disease outbreak. That's the key point here, is that from the federal government, the first level of supply would arrive at one point, and that is where the state location is. It's one point for each of the state where all the supply will actually arrive here. And then it will go to the second level, that is the distribution sites. That means from one particular location in the state, it will go to distribution sites, and then from there it will distribute to the pod, that is the point of dispensing. So that's how the situation is located. Now, if you're going to stockpile, you're going to, of course, stock it in different locations. So from the population side, how do people actually move around? So you have population from outside, you're going to move them around. in different locations. So first you go through the security, and also this is like a registration, right? So everybody comes in, they register, and if we go through the biological attack, then that means there will be security, there will be military and police enforcement here. Once they're all clear, then they go through to the point of dispensing, where they actually receive the medication. Now remember, we are talking about prophylactic dispensing. That means in the population, there are people that are infected, there are also people that are not infected. So that's very important. So the motivation is that in response to biological and also acute infectious disease outbreak, then there's an urgent need, and that's basically come down from the federal government in 2001, is that we have to establish the regional treatment centers. We need to be able to develop procedures and policies and planning framework for such things to happen, is that efficient allocation of resources and staff. And that's where the starting of our project is, that CDC asked us to look at the system in 2002, and it's really after a whole year until then is that we really start building some of the systems. So some of the challenges I'm going to look at, like as I mentioned in the earlier, one is the medication, where it actually comes down from the federal government all the way to the state to the point of dispensing. The other one is that we're looking at the logistics of the population. How do you actually mobilize that? So if you are given a regional population, now we are not going to look at all the complexity of it. We're going to look at the big picture so that we can design the strategic planning. Then we look at the operational level, where how do you actually staff each of these clinics. So given the regional population, you want to know where to put up these facilities and how many do we need to use that in order to actually protect the entire population. And we also need to look at where should we actually, how do we actually assign these individuals to each of the pod. That means you are going to give them a route so that they actually could come in. And within the facility, how do you design the layout, and how do you perform the staffing needs so that you actually could perform the required output. In the federal level, in terms of the medication, as I mentioned, is that there's a stockpile and there's the push package. If there is really, for example, if there is an anthrax attack, there will be 24 hours of time frame in which the government can actually confirm 100% that the powder is actually anthrax. It will take 24 hours. And once it is declared that is the case and that there has to be a regional protection, there will be a 12 hours, which we call the push package period. That means the federal government, all these are stored in a place where it is called push package. That means that it's the first round of emergency medication that we send out. We send it all the way to the one point in the state, and that's where the distribution is. For these 12 hours, the regions is going to set up the facility, and then they will await for those medication to arrive. Once this push package is done, then in order to protect the entire population of that region, then all the inventory will come from warehouses. Okay, so you see the difference. In the state, of course, they're not going to be running on empty fuel. So what they do is that they will have warehouses where they actually start stockpiling. Sometimes it is difficult. For medication, there is expiration date. For vaccine, there's the storage where you need refrigerator. You need many different things in order to actually store those things. So there's the stockpile in terms of like how much to keep in your storage and how much you actually need in terms of emergency needs. And so there's the receiving side and how do you actually distribute it properly. So you can see a large network of problems that we can look at. So one of the earliest work is by CDC. These are industrial engineers that work in CDC's Mason and Washington, actually developed the CDC MaxiVac. MaxiVac basically is a guideline to help the public health planners to figure out what are the resources that you need in terms of like if you have to protect your regional population against infectious disease outbreak. So this basically is a computer simulated event, a discrete event simulation model, and coupled with optimization where you do the resource allocation. So clearly, if CDC actually did the protocol and actually did some of the benchmark, what they did show is that it is very important to have a computerized decision support system that can help that. No doubt about that, but you know that. Cannot do it manually, but that's exactly what healthcare people are doing now. Everything, a lot of the things they do are manually. Even though it could be smart manual versus like just a wild guess, but still they rely a lot on guesswork. But they also show, what CDC show is that there's bottleneck in assimilation and optimization. And for those of us, if you study mathematics, it's not difficult to know resource allocation under limited means, and also you have to assign staff, and that is integer programming. So that is clearly, it's a difficult problem. Not only that, you are not just optimizing one problem, you're optimizing over the simulated event, right? So it's like you keep updating the information and you keep optimizing until you reach a state where the assignment is optimal. So it's difficult. Then there was a few tests in Arlington where it showed that it is very critical to have an on-the-fly decision support system. Not only you're going to have a system that allows you to do operational planning, you also need one that allows you to do catastrophic. In the case of catastrophic event, you can actually do dynamic changes. We always do dynamic changes. How do they do it? They just do it by whatever they see something happen, they just mobilize, right? So that's the part. One thing that we have to do to understand is that it is not true if they don't have these tools, can they do anything? Yes, they can do something, but they're not doing the best things under the uncertainty and the limited resources. So that's the effort from Georgia Tech team. Real opt is resource allocation and optimization. And from my CDC's colleagues' standpoint, it is real-time optimization because it also has to be fast, and that's it. So it is targeted at like allowing the state to perform studies, training, and enhancement of emergency response. And it is a decision support system for population flow planning, medication flow planning, and also real-time resource allocation. It has optimization and simulation coupled together with scientific advances where you want high-performance computing also to actually work under a very simple device. How simple is this? You want it to run on a PDA. So you want it to be really a system that sounds like it is very complex, but actually you want to develop it that it is simple enough to run. And of course, it allows operation and strategic planning. So in the front end, it's the users actually just looking at the system, and then they will put in some of these information, and then it will perform simulation and optimizations. And these are like, for regional workers, this will be what they could do is they can estimate the resource they have, they can assess the budget, they can actually look at regional facility layout and how do they place these facilities in different locations, the staffing within each of it, and training of personnel. And also one of the key things is that we really don't have a lot of information in terms of data. That means the time motion study is critical, and that is the knowledge data bank that we actually are creating for the nation. And on top of that, that's a very interesting disease propagation study where we actually look at how disease spread and how it actually spread across the facility, so that as a manager overseeing these operations, you know precisely how to actually modify your staffing so that you can mitigate the amount of disease propagation. In the federal level, what is being used is for movement of medications from one site to another site in a way that is, of course, safe as well as fast. One thing that is interesting is that a lot of these things are just in time, and it's easy for us to understand in case of emergency, natural disaster, or man-made disaster, is that we do need to ensure that it is just in time. You cannot just send everything in, but when it's needed, you must have it. So large-scale dispensing, I'm going to talk focusing on the population flow because I don't think I will have enough time to talk about all of this, but as you see, I want to show you the big picture, what we are looking at. So we're going to look at large-scale dispensing. So once the federal government confirmed the spread of biological and infectious disease outbreak, then it will require the prophylactic dispensing. So what exactly do we have now in the federal, in terms of the stockpile? We have vaccinations for smallpox. 100% of the population is covered. So we basically have vaccine for every individual. For pandemic, obviously, pandemic flu, you all know that you and I are not going to get the vaccination because we are the healthy and the not in the group that have the priorities. And those, of course, have priorities in terms of like who will be getting those vaccine. Then for anthrax, there's also antibiotics that is available for the entire population. How do we actually deliver these things to everybody? So the talk that I'm going to talk about, what's following, will be the ones that we talk about setting up facilities. But there will also be, and I want to mention that here in terms of the multi-modalities, is that it is not just setting up the facilities. There will be delivery through the, basically to the prison, to airport, where we actually set up facilities right there, to hotels, to the homeless people. There will be also drive-through in the rural areas where it will be easier to just set up places where people drive through and pick up the medication, right? So that's what the modalities. The idea is that you want to use all these to cover your whole population. Doesn't matter whether they are actually residents inside your region or not, because you cannot possibly just protect the people in your own region and then all these people that are on travel, you just leave them behind and say, okay, now we don't know what to do with them. But that's a big part that we have to deal with. So just to give you an idea about a smallpox layout. Now, it's an interesting thing. I don't know how many of you actually know how smallpox looks in terms of the disease, because even among the nurses, it is not easy for them to actually figure out what smallpox is, because we don't have smallpox incidents in the US for a long time. So basically, I call this patient. They're really not patient, right? They're just like you and me. You just arrive at the place. Triage is the most critical part for infectious disease. One of the key part is that not only you're going to have to identify if people are contaminated, that means maybe they are infected, or if they are not infected. So that's the three groups of people. One is the group that is suspected to be infected. The other group is good and not infected. Another one is good but worried. Right? The group that they probably are not infected, but they are worried. So they need more time to go through the triage to figure out if they have any chance to come across the infectious disease, and then they may need some advice on what to do. So once we go through that, then we're going to check if they need treatment or not. So there are two types of treatments. One is prophylactic treatment. So that's like if they can take the prophylactic treatment, they will go to the orientation room. If not, then they can exit. Or for the individuals that actually is contaminated, then they actually will also be sent to the clinic, right, where they will be treated. Then the orientation room, this is actually really critical, is that because the 5 infectious disease agent and also biological agent that we look at, really none of those is very familiar with, anybody would not be too familiar with. So the orientation room actually consists of like a video room where people can view the symptoms of the disease and how do they take care of themselves once they take the vaccination and all this. And they will be filling up forms about their health conditions and consent. And if they need help, the staff will assist them. Otherwise, they fill out the form themselves. Staff will look at the forms. Then there's another step to double check all the forms and everything is answered properly, and then the individuals don't have further questions. Now, one of the key things here, and I think Margaret and Rich have articulated really well, is that it's not like every step is not like we're going through like a little robot. They say, okay, yes, no, yes, no. You notice that, right? Questions that is being asked, sometimes you really don't know if you have these conditions, or you will have a lot of questions asking that. Besides, even in the case of emergency, when you actually are going to inject a vaccination on an individual, you are going to have to follow through all these health guidelines. That means you cannot just say, okay, now you fill the form, I'm going to just poke a needle in your... You can't. You have to ask them, do they understand things? Because there's a lot of legal issues involved in it. And then once everything is clear, then they will be sent that. This clinician might not do too much here. All that they do is just poke a needle in, and they said 9 seconds, they will be done. Don't know if that's how long it takes, and you can ask questions, they might not answer. So, and then you exit, and then the staff will answer questions that you may have in terms of like questions that you say, how do you take care of yourself? And then you sign off and exit. So this is a smallpox clinic. Even getting this clinic itself is complex. It took several years before we actually iron out like what are the details, like what are the steps that has to be there. So in the prophylactic case, then you are given a population. Now we're going to look at how do you determine the facilities that is needed. So let's look at these two. So I will show you from the small scale versus the larger scale one. Just pick a county here. This is a county in Georgia. This is the DeKalb County. So these are the sites. This is really for bioterrors, actually, facilities. So we actually identify all these sites, and shortly after we identify all these sites, of course, they become all vulnerable now. All these sites are eliminated, and then we start all over again. So that's also one of the really difficult part, is that when we actually locate these sites and do planning, these sites would become very vulnerable in terms of like for the target attack in the future. So these are the 20 locations. And basically multiple objectives. There are many objectives that we are looking at. So you want the system to give you a solution that is good, but you also do not want to put too many objectives in it so that it becomes so complex that you might not be able to even find a solution that satisfies everything. So here we are looking at minimizing the average distance to the closest dispensing locations, as well as minimizing the facility setup time. So that's, again, the region. So you can discretize it, and different shades correspond to different, different shades can be used to show the density. And we actually do use the different density in regions. And these are the spots for showing you the possible facilities that we can place. So the task is that we want to make sure that every household is assigned to one port. In the case of Amtrak's, you don't just come in to get medication. It's just that one representative from each household is coming in. So we want to make sure every household is assigned to one port, and we want to maximize the capacity of the throughput of these locations. So every site has physical constraints, and I didn't put inside there's fire regulation codes and all these things, and basically every site has its own physical constraints, and there's maximum number of pods that we want to cover in the entire region. Computationally, this is extraordinarily hard, because even for a region that is not that big, and I'm going to show you that, really, if you just put it in CPLEX, and no matter how you actually come up with those flats that you set in CPLEX, it takes my students will say 1 week, no solution, what are we going to do? I said, get a solution, right? What are you going to do? You must find a solution. So it is, in some sense, this is kind of nice. I suppose it is difficult for OR people. If they're going to do a problem that has trivial solution, they can publish papers in an area where the colleagues may not appreciate, right? So one of the things that I'm not complaining in a sense here is that we're doing real problems, and we also at the same time can advance the theory and computational area. So that's nice. It is not always possible, but we appreciate in terms of being able to do a real problem. So this is just to show you, this is for DeKalb County. Now this is the efficient frontier showing the trade-offs of these two objectives in terms of distance travel versus the number of facilities. Now these miles may not mean too much to you if you say, okay, 3 miles versus 7 miles. But just to give you an idea, in Atlanta, even if you're 4 miles from a place, when it is not busy, it may take you 8 minutes. But if it is really busy with the traffic and everything, it will take you 1 whole hour. So you have to be realistic in terms of how far will you be setting up these facilities from the locations where people live. So now that's the optimal locations that we have determined. And the color code actually show you the regions of people that are assigned. And actually, if you want to look at put a microscope and look under that, every household will have a path. One of the challenge, I guess Fred could testify if that's the key or not. In Atlanta, the streets are very weird. You would drive all the way straight, and all of a sudden it changed its name. So you must give them a path, because otherwise they really would not know where to go. It is not easy to find the path even on some of the Google map, and they would still give you wrong directions. So this is one of the things that when I show the result, everybody asks me, do you mean that everybody knows the path? I say, yes, we actually have it, but we're not going to show it right here. So now that's the challenge here, is that's the small county here. So for the city readiness, actually it consists of 11 districts making up of all these counties, and that consists of 5.2 million people, and that's what the city readiness program in Georgia. And what we have to do is we have to design the facilities for each of these. More critical is that each of these districts has different judiciary regulations and everything, all the needs. And sometimes they don't share things, and sometimes they do. And that's actually makes things a lot harder in terms of how do you actually be able to share things. So just to show you, this one takes a long time to get this, because it is a large-scale problems, and it shows you the number of facilities required versus the maximum allowed travel distance for each of the households. So you see the difference of the number. Now the manager look at that and say they decide how many pots, how many facilities they want. And this is one solution. I won't show you too many. This solution actually show you the facilities in each of these locations. The big dots represent like each of the size of the dots correspond to the capacity and the throughput per hour. So some of them really run very high. Like as you see, the smallest dot is 500 per hour, whereas this one is between 500 to 2,000, and these guys. Now, this is also very interesting. These are the most density. This is the DeKalb and the Fulton County. Is that these are the ones within the city that has really high density of population. So you will see that they have the pods actually have to actually funnel in a lot of population. And that actually, I should mention that it also creates challenges here is that now you cannot just let everybody drive in because in the city there's no parking spot. So that's another challenge. But I'm not showing you the detail of the things. I just want you to see the big picture, and then you will see all the little things that actually come in, and you will have to make your solution practical. That's the most important thing. So the next step now, once you know how many pods that you want to set up, then you have to determine how many staffing we need. So one of the critical things is that the cities never really have enough resources. They never have enough nurses. They don't have enough first responders. So how else are we going to actually protect everybody if we don't know how to actually manage the resources? So this one actually really is a complex problem, but on the other hand, it's also very intuitive. You can think about like you have different workstations in this facility. You need to assign individuals to different stations, and then you have maximum number of individuals that you have with different skills, and you have the average wait time, queue length, and utilization. Now, you are going to appreciate exactly why we care about the queue length or the wait time. It's very critical. And also the average cycle time. That means how long an individual is inside the facility. Cost. The cost of using personnel, as well as the cost of wait time, queue length, and utilization. You really cannot let them wait too long. And that's like it's coming up, and I will mention that. So the idea is that you want to maximize the throughput because you need to finish everybody, right, within a very short time. You want to equalize utilization because you want the workers to have sufficient amount of work and that they're not overworked. There's a lot of constraints, and this is not a closed form, so it means that you're not going to expect it to achieve the steady state, and you cannot just use analytic approach. So here's the Amtrak exercise. I'm showing this one. We actually did several of them around the United States, and we performed some time motion study. So this one, basically, the public comes in, arriving through transportation. They go through the security point. They are being asked questions if they have about Amtrak and what they have to do. And that's the medical evaluation. That means if you have any medical conditions that you would like to ask questions, you can ask. Mental health. So this is complex. This is not about people that are crazy. That's okay. That's the group that we need to know also. But that's also more critical is that these will be the people that come in and they become very nervous. So human factors is a big thing. Asking human beings to actually work under very critical condition or very emergency situation is difficult, even for the workers. But then you have individuals come in, don't know a whole lot of things, they become really nervous. So one of the key parts is that we want to make sure that these people are being taken care of. We pull them out from the crowd so that they don't cause disturbance. And that we actually saw it in the exercise. It's a very interesting thing because the individuals do not know what's going on and they become very nervous. Once everything's clear, they are being bussed to the point of dispensing. Once they arrive here, half an hour later, maybe they were on the bus ride, and they should know very well like what to expect and everything. So they should be calmer, but still, even here, we still have the mental health part that help them to calm down if they need any assistance. Then for those that go through okay, then they have the drug dispensing and then they depart. So this is the number of households in that region, 864,000 households. And we have 5 assembly point and port pairs. That means there's 5 locations where people can come in and for the security check and everything. Then there are 5 ports that we will ship the individuals. The workers work for 12-hour shift. The goal for this particular exercise and also for this test is really to finish everything in 24 hours after you receive the medication from the federal government. So the task is determine the resources that we need. So that's just to show you, we actually come back like how many staffing that we need for 12-hour shift, right? So basically that's what they have to do. And then you can actually, within these staffing, you can actually see also the nurses that you need and the healthcare workers, volunteers, people of different capability. So the actual planning in some sense, if you look at it as just a deterministic system and forget about all the variation in the service time and everything, you can actually find an estimate just to really cope with this population size, but it won't give you a very efficient operation. But now we actually include all the stochastic factors, and we also include human fatigue and lunch break and the break sections for each of the workers. And one of the key things about emergency response is that we really have to take care of the emergency workers, because these are the first line of responders, and if they are not doing well and if they get too tired, they get sick, then we lost a very valuable resource. So that's one thing that we actually plan. The way it is planned is that we want to make sure that they are working well under stress. And then the workers were mobilized to cover many different type of planning staff, and we basically look at, for this particular exercise, really just for 1 hour and 1 hour and 50 minutes or something, and the throughput is only 450. Interesting enough, there are 8 counties that is involved in this exercise, and we actually were assigned to pick up the county that did the worst last year. So they were not able to do a very good job, and CDC said, okay, let's take care of them. And so at the end, of course, they became the star, because this time we actually did everything to help them in all the aspects. And I will mention one of the aspects that we didn't help, and they really didn't do well. And it shows you the collaborations is important, because we won't be able to help them to plan if we don't know the physical locations and all the population size, as well as what exactly do they want to see. They were able to process the most number of individuals, and the planning itself is also very efficient. So what we see is the following for that exercise. There are external evaluators from companies that actually evaluate and give them grades and markings on different steps. They have the most efficient floor plan, because the clinic itself doesn't have any cross in paths, and most cost efficient because they use fewer number of staff compared to the other. And the operations is the smoothest. That means it doesn't have a lot of chaos going on, even though the bus drivers get lost and that's interesting. And then some of you already have heard me talk about that. During the exercise, 2 buses were lost. And how did I know that? Because my students were on those buses and doing the time motion study. And at the end, we are all done, except 2 buses didn't arrive. And I asked them, where were you? They said, well, the bus driver told us he knew a shorter path. And he took a shorter path. And the funny thing is that it was all manned by policemen. I don't know how they actually even got out of that route. So it shows you, right? It is really not an easy thing to do. Emergency thing. Everybody is trying to do their best. But even with that, it shows a lot of problem. So the study did show the following. Even without historical data, we seem to be able to plan well. But that is not really expecting that, and also that is really only one incidence, right? We are collecting a lot of data now to help with that, so that we have a national library for that. The exercise also tells us a lot of information in terms of the little things can help, like the language barrier is important, because you only need one individual to get confused, and then it messes up everything. And another thing, like I mentioned, is the bus driver was lost, and it's not clear why that would have been the case. So we are collecting many data now in terms of in all the exercise drills around the nation. So one of the key things really for us to do is there's so much learning after the exercise. So this is the collection. We're very lucky because we actually collect many data during the exercise. So then after the event, we actually perform analysis on all this, and just the surface time to figure out how it looks. And this I will just show you that. So one of the key things that the CDC asks us, and there's also there's also some debate, and I think it is fair for me to say argument between CDC and the states. And you can see whenever you talk about public health service, it is difficult because the federal government work with the state, and the state work with the local local agents to take care of everything. And I was told that federal government always talk to the state, and the state always talk to the people under, and never the people here talk to CDC. So there's all these complex things. Is everybody is working on a common goal, but the communication is in a different level, so they cannot cross. And I'm the only one, since I am outside, so I can talk to everybody without having this constraint. But one of the information here is that, can we actually have the security and the port combined together? Is it better or not? So we are talking about, you do not need to think about bioterrorism. Of course, if it is bioterrorism, that's even more critical. But just think about infectious disease outbreak. Pandemic, flu, what will you do? Are we going to bust people in? You will never do that, right? So that's why right at the beginning in the talk I told you, this is not for flu pandemic, because when there's a flu pandemic, your best way to protect yourself is to stay at home. The study already has shown in Asia, they have done the exercise on testing that. So because we won't get vaccination anyway, so your good way is to just protect yourself from anybody so that you won't get infected. So we won't bust anybody. This is really about a different type of infectious disease and also biological attack. So can we put that in together like this? This is for the Amtrak stuff. Is that individuals come in, there's security, they go through triage, and then we dispense them. So it is in one physical location. So now if we are going to think about biological attack, it's very different, right? What's happening is that if there is an attack in the security point, now one thing that we see is that everybody has to go through the security point. So this is the most vulnerable place. If we combine these two together, if there is a catastrophic event here, we are going to collapse the entire part, right? So that's the key part. But if you look at just how many people we use to man that, of course, you can see that we use fewer people in different levels. So combining that is, of course, the cycle time. That means the amount of time people stay inside is shorter. And that is good because the longer the individuals stay inside, the more panic they get. And we saw that even in the exercise. They got very nervous. They don't know what's happening. People start to feel really like want to do something and not following the crowd. So that's the lessons that we learned. And we also see that fewer healthcare workers need to man each of the stations. And we don't need the policemen to actually man the bus route. That may be good, right? Because somehow the bus drivers were able to get out of the path anyway. So we reduced the bus usage. But when it comes to security, this will be a big hole in the event if there is an attack, is that not only we collapse the assembly point, we collapse the entire point of dispensing. That means we won't be able to actually dispense. And that's something that CDC and the state are kind of like fighting about what is the best way. But they're really looking at biological attack. So one of the things that we see is that we are able to do the large-scale scenario very fast. That's really the design of the system, not by chance. It is really that's what they want. We can actually facilitate the preparedness. And one of the things that we really learn well is that you have to look at not just the optimization itself, you also need to provide the technology for them so that they can actually put it in place. And that's very important, is that putting in what we do actually into practice. And one of the key things is that not only you're going to do exercise. Exercise contains, 10,000 people at most. The largest exercise that we had actually observed was 10,000 individuals coming in, which is a very large scale. It's like chaos in terms of like just managing that. But you have 10,000 individuals that is coming in. That means the number of workers is also a huge number. And that is for virtual exercise. Virtual exercise gives you the ability to look at different scenarios. So you can actually look at the human factors. And that's part of the things that you would like to be able to learn from that. And now, as I mentioned, is that this is an interesting, this is not a system that we actually built originally for real-time usage, but as it turns out, that's what they are going to use it. That it actually overcomes computational bottleneck that we see in the commercial systems, and it offers a very interesting framework for them to start thinking. So one would think this is the end of the collaboration because we deliver something they can do a lot of analysis. Is actually just the beginning, because as they start looking at things, then they can think of many different things that they want to analyze. And that's the beauty of it too, is that it allows them to start open up the thinking and imagining what's going on and start to actually do the planning. And it's actually available for free. And that's one of the things. It also taught me something, because a lot of the systems that we have built, like the cancer system that I have, actually is commercialized and it's available. You can buy it through commercial vendor. But this system is actually free, and part of the reason is that CDC makes a huge point that if we build a system and you actually ask them to pay for it, they will never be able to afford it. So that's one thing that's an interesting thing. So we built it in a platform that required them with nothing. So for those of you, if you're interested in doing public service research, that's one of the things that you notice, is that public health, in some sense, that we can actually get fundings in doing research and everything. But when it comes to really putting the policy in place, putting the decision-making part into the hands of the manager, you do notice that they are very poor. They don't have a whole lot of money, not only limited resources, they basically have sometimes no resources, but yet they have a lot of guidelines they have to follow. Like the federal government basically say every city has to have these city readiness plan, but there's no funding whatsoever to help them, right? So that's the part that they have to learn. So when we start building this one, we had not much choice. We had to start on every level with everything free. So that's basically why we actually end up using Java, because instead of like, you don't have to use any software. Like if you use Excel, even though you would assume they will be able to spend the money on a lot of the things, they can't, basically. So we basically build everything from scratch. It's a Java program, and it turns out to be actually very important, because the first day after we do the demo and when they do the exercise, the first thing they say, well, can I run it on a PDA? I say, I don't know. I say, I know that that was not my plan. I thought they would run it on a laptop, but yes, you can run this on a PDA too. So it's an interesting, it's this on-demand constraints and also objective as they like dynamically change as we do that. So that's basically what I want to talk about, because I don't think I would like to have more like interactions in terms of like the questions that you want to ask about. In terms of for mathematics students, I think there's no shortage of problems out there that has a lot of mathematics in it. Very rich mathematics, yet the application itself is very worthwhile. Like for this one problem, I won't say that you can just solve them for free. No, you can't. You really have to think about the mathematics and come back with a solution that they can use. And that is the beauty of it. So sometimes we are very lucky. We bump into like the cancer problem that we do. It's also turned out to have a lot of mathematics to it. So we are very fortunate to be able to write papers on theorems and proofs where that is traditionally being at least being accepted as the standard way of showing that we actually have the ability to do the work. And then on the other side, you can actually publish really, really good papers in prestigious journals where they actually accept your view and knowing that you can actually put it in practice. So that's an interesting part. Like I certainly have never thought of like studying mathematics would be limited. I mean, in some sense, because I have all my degrees in mathematics, so I can't complain about that, but it does give me a lot of advantage, because in fact I can do a lot of things. And OR, that is the blessing and the curse, right? OR is the broadest field that you can imagine. It has every single scientific things that you want to put into it. Here you see the optimization, you see the simulation, you see the system design of the system, you see the software development, you see human factors, and you basically can see every single thing and how they all put together. So you cannot just say, okay, I'm just going to nail this problem and I forget about whether they can actually use it or not, right? So that's the translation of the work into that, and it's a very nice example to show that. And certainly I think like Susan's goal of like putting OR into the math curriculum is perfect, because that's exactly what we want. Because then, now the curse of OR, like I always say to say that is blessings is because we can do everything, right? Then the curse is that every time you tell people you are like your major or your research is in operations research, you really need time to tell them what does that mean. And this could be a curse in a sense that you always have to explain, but I can even see it as a blessing, right? Because you have more time. to interact with that individual. One of the things that is really key, and it doesn't show in a lot of the things. Yes, you can write theorems and you can write proofs and you spend time on your own in a dark room or whatever you want to do. That's very different. When you actually go out and work with people, and that is really the hardest because you have to meet so many people. You can ask my students and they will tell you just every single thing that they cannot expect. Right? They have to talk to the healthcare workers, and then they say, can you believe they don't even know how to turn on this button? I say, oh yes, of course I believe that. So there's a lot of things to learn, right? It makes you, in a sense, appreciate the complexity as well as the simplicity of things and how the different people actually interact. And I think that's beautiful, but that is very time consuming. And Margaret already mentioned about the data collection. Sometimes it's really amazing because you go and ask the doctor, do you have the data? They say yes. And then you ask them, can I have the data? Okay, the answer is yes, maybe you can have it or maybe you can't, right? So the whole implication is, and by the time they give you the data, you see more problem because their idea of data from their point of view is totally different from our point of view. So the first example that I can show you is that when I started doing the cancer research, prostate cancer, I asked them for patient data. They actually literally gave me the patient chart of every individual of their patient. Yes, now I cannot complain, right? I have every single data, but you don't know what it means. So it is very interesting. With healthcare now, of course, we learn, right? With my students, it's also not easy because they go in and they say, oh, I cannot pronounce those words, like about the medical stuff, not to mention about any questions to ask that is intelligent, right? They say, every question I ask is going to be very stupid because I don't know any of this. So this is an interesting thing to learn. And mathematicians, I think, sometimes may find that harder because that's the interaction, whether you actually could succeed or not. You not only you have to learn the language, you're not going to expect them to speak your language, that's for sure. But one of the things we have advantage is that we seem to be OR people, right? Seem to be pretty good in learning others' language. Understand the problem, at least build a solution that can be used. And that's, I think, I'm going to close in here. The computational, which one, the facility location or the, okay. Both of them are hard. So this one is basically stochastic, right? You go through the simulation, you pick up the statistics on the wait time, the queue length, and the utilization, and then you perform the optimization. You go back in, it's a stochastic multiple steps of optimization. So this is extraordinarily difficult. So if you actually now building this model is easy, right? You all know ARENA, so you can build the discrete discrete event simulation, and try that for 1,000 individuals with 30 people. Just you need to do the assignment. After 10 hours, you won't get an assignment. It's just stuck there. It can't solve the optimization. So it's difficult. It's not even one round of optimization that they are able to do. It's many rounds of optimization. So that's the challenge. And we are doing, as you notice, we're doing 864,000 household. So the CDC benchmark is only 1,000. So I didn't show that benchmark, but it's only 1,000 people that they were able to do. And that was validated by quite a few of the vendors. We actually asked them to test it. And the first thing, the vendors get really upset. What are these problems first? Yeah.
That's part of my question.
Yeah. The vendors are really upset. First, what are these problems? And secondly, are they real? I say, sure. Of course, they are as real as you can imagine, right? These are problems coming right from the state. So they are hard. And then facility location basically determine the number of facilities you need to cover the entire region, given the physical capacity of each of the possible locations.
For the other problem, would you argue that your solution, your open source Java solution, is a better approach or generates a better set of minimization and maximization outcomes as opposed to the commercial alternatives?
Definitely
That
the
was
solution.
my takeaway from that other
Yeah,
point?
but we are not. Yes, but we are not just a better solution, right? Remember, if you
For
don't,
this domain space.
yeah, yeah, it's you can if you cannot even find a solution or a solution that can be used, right? So that's important. And one of the things is that for emergency response is critical is that you would like to be able to train on the fly. There are not many managers that would say, okay, I know exactly where to place the facilities and how many people to put or where to route. Yes, if they have 20 years of experience, they probably will do much better. But many of them don't have a lot of experience. And how do you actually come back with the solution that actually is good? And that's important. Emergency response, like in terms of some of these work is used in hurricane, in the response of like disasters. They use that to set up shelters. And that's also why we actually put in the capability of the disease propagation study, because whenever there is the disaster, the key part, people don't die just from the disaster. People died also after they are being put in the shelters and the hygiene and everything, right? You are jamming a huge number of people. We saw that right there after Katrina, because we just have the system. We just have influx of like 3,000, not that many, right? 3,000 people from New Orleans. And then they used the system right away to set up the shelter. And that was interesting because they said, oh, 3,000 people, it seemed really small. No, but you have to feed them. You have to make sure they are healthy. You have to assign the nurse and everything. So like I say, I showed you really very high level view, right? But you can fill in the blanks. I'm not going to say, okay, let's take a look at what's inside the shelter, because you would be able to actually see that, the complexity of the problem. And you cannot just show all of the complexity, because you also need, as a central commander, you also need to see the big picture so that you actually know what to do. So, but the computational challenge is there because the facility location is very difficult. And like I used to give problems to Bixby, like the cancer problem, and he got so mad at me because CPLEX is really very good, right? Everybody agrees, and 90% of the industrial applications are solved by CPLEX. And there is like, I was his student, and I said, would you please try this problem for me? And he would come back and say, what type of problem are you looking at? And they are not moving. I say, like, and he got so mad because it is different. I mean, that's the things that we are good at are deterministic problems, right? Things that have schedules and things that are rigid. But then you have stochastic nature of human things, of all this complexity in it, and it becomes a lot more complex. But you don't, like Margaret said, you don't want the model to be too complex, because if you cannot solve it, it does not matter how well your model is. So you kind of want to push that envelope to be like as high as possible. And for students, that's also perfect, is that there's still an appreciation of theorems. So for the students, they always say, when am I going to graduate if it is so hard? I say, that's good. I say, you have a problem that is hard enough, you can get a thesis out of it, right? If you solve it in 2 minutes, I don't think anybody is going to sign your little thesis. So it's a trade-off there. But I think for PhD students, sometimes it is difficult because they don't know what their actual contribution is and how others are going to evaluate them. So there is some nice things. And then sometimes we have to make the problem in such a way that there is the part that we can do the theory. Like the cancer stuff is natural. We actually were able to do the theory as well as the computation. But sometimes there's none. Then you actually give them a solution and you learn the process. And also you improve some of the practice outside. So, but I mean, I want to show you this is because, like, sometimes it's really difficult for us to determine what to do, and it's not so easy when you first look at it. Like the problem seems maybe like more just like you just do all the hard work in data collection and understanding it, and there may not be any theoretical stuff, and we cannot guarantee that that's always the first step to start everything. But data is ugly. Data in healthcare, in public health, as Margaret mentioned about how long it took her, and data in the clinic is even uglier. So that's like, everybody says that they cannot do the work because there is no data. Now, you cannot say that. There's a huge amount of data out there, right? Gigantic amount of data about biological stuff and medical stuff. The challenge is not that there's no data. The challenge is there's a lot of data, and you do not know how to process it, even to build a model. That's really the challenge, and the data is ugly and noisy, and you do not know how much to trust, right? For us, we like to say, okay, here's the schedule. We know exactly, even though you get upset if the plane doesn't leave within 5 minutes, but that's 5 minutes, right? Surgery, I can tell you, prostate cancer. Once I went in 6 a.m., we're done at 8. Then I went in another one, 6 a.m. We're not done until like 3 p.m. And I was like hungry, starving to death. I have no idea when we will finish. And that's the same procedure. Same procedure, right? So you can see the variation when it comes to involving human is very different than machinery. And then the next time you complain about the plane, of course, mechanical thing is different. So there's a lot of things like in terms of medicine. And for students, I think that's a big step for them to learn, because they were quite shocked. I mean, in terms of like when they go to the clinic, they say, wow, this is the same procedure. How come it's totally different? And you will only appreciate it when you are in the clinic. And that's the first thing I learned when I started the cancer work, is that the clinicians say, Eva, I'm not going to talk to you about anything. Just go down to the clinic and see it yourself, and you will appreciate it. And that's really true. I think for students here is that I think some of the projects that you do, if you have real problems, just put them right there in the practical environment, and they will know. You can see mathematics can do everything, do all the wonders. That's not only your theorem works, right, when you prove it, it also works in practice, and that's even more beautiful.